Namaste and good afternoon. Greetings from all of us at Apollo Hospitals. This is Dr. Srinidhi Chidambaram, and I'm very happy to see all of you again. Today is International Thalassemia Day, and this year the theme is Be Aware, Share, and Care. And one of the main goals is to work with the global community as one to improve the knowledge about thalassemia. You are aware that Apollo Hospitals has always been at the forefront in creating health awareness, and we have been doing numerous sessions on Facebook, which has been bringing you authentic information on various health conditions. So, here is the perfect topic for us today: thalassemia. You may be aware that thalassemia is an inherited blood disorder, and it is caused when the body does not make enough of a protein, which is called hemoglobin, and that's an important part of our red blood cells. So when there isn't enough hemoglobin, then the body's red blood cells are not normal, they don't function properly. And there are two types of thalassemia, alpha and beta. But in India, beta thalassemia is prevalent much more, and there is also quite a high frequency of carriers. And it is estimated, as per the government of India, that there are about 10,000 to 15,000 babies who are born with thalassemia major every year. And there are certain communities and regions in India who are also more prone to thalassemia. And the cure available, while the definitive cure is a bone marrow transplant, for many people, what is affordable is a lifetime of regular blood transfusions and iron chelation therapy. So definitely an awareness about thalassemia and a concentrated effort towards education is much needed. So to explain thalassemia to us in greater detail, I'm very happy to welcome Dr. Purvi Kadakia Kutty. Dr. Purvi is an MD in pediatrics, an FNB pediatric hematology and oncology specialist, and she's a senior consultant in pediatric hematology and oncology at the Apollo Cancer Centers, Navi, Mumbai. She has an experience of over 10 years in the field of pediatric hematology, immunology, and oncology, and pediatric bone marrow transplants for both benign and malignant hematological conditions. Dr. Purvi completed her undergraduate medical education from the TN Medical College and Nair Hospital, Mumbai in the year 2003, and then pursued her postgraduate training in pediatrics from the same institute. She also completed a prestigious 2-year fellowship program conducted by the National Board of Examinations at the Wadia Children's Hospital, and also has a fellowship in the same field from the Indian Academy of Pediatrics. Dr. Kadakia Kutty was the assistant professor pediatric oncology from 2013 to 17, participated in multiple national and international clinical trials in thalassemia, hemophilia, and childhood cancer survivorship programs. She's also keenly interested in teaching and has to her credit numerous publications, oral and poster presentations in various national and international conferences, contributed to chapters in textbooks, and affiliated with several societies such as the MHG, INPOG, SIOP, and so on of the Indian Academy of Pediatrics. So, welcome, Doctor, to this Facebook session on International Thalassemia Day. I'm so happy that you could join us. So, maybe we could begin with just a definition of what exactly is thalassemia. Over to you.
Yes. Thank you for that kind information. Thalassemia, as we all know, is a genetic disorder. So it is inherited just as a trait is passed from parents to their children. Similarly, the trait for thalassemia is also inherited by a child from his mother and father. And this trait confers an abnormal hemoglobin protein. So this leads to rapid destruction of the red blood cells, and there is hemolysis. So the red blood cells do not survive as they would survive in a normal individual. This leads to anemia, and it is a disorder which is inherited, remains lifelong, and cannot be cured, needs regular blood transfusions lifelong to survive.
Right. So when we say that this is a genetic inherited condition, could you tell us what is the pattern of inheritance and is it so how does one determine this?
So, this is a monogenic disorder in which both the parents must be a trait. The child has a chance of 25%. So, there, with each pregnancy, there is a 25% chance that you will have a full blown thalassemia major or a disease. 50% chance there will be with each pregnancy that the child may be a trait, just like the parent, and 25% chance that he may be a normal individual. So, this is inherited from the parents to the child. It is autosomal recessive mode of inheritance.
Which means that both the parents must have a trait.
Yes,
So,
yes.
so, how do we really identify? So, one important aspect is the prevention of thalassemia. So, maybe we could discuss a little bit about what people must know about this and is it prevalent in certain families or is it random? And also that is there some opportunity for people to kind of assess that there might be how do they know that they have a trait, for example?
Yes. So a thalassemia trait or a carrier, it's a carrier state. It is not a disease state, and it will be picked up on a routine CBC or a complete blood test, where the carrier will always have a low hemoglobin with low red blood cell indices, and this will persist lifelong. But this is not a disease. Carrier states are individuals are asymptomatic throughout their life, and they do not need any treatment. But when does it become important? Because the burden of thalassemia major is so high in our country, we must identify these carriers. So there should be voluntary testing, either at the age of school age or college students, or even when you're about to plan a pregnancy or a family, you must get yourself tested for a trait. If you've not had a CBC, you must do a hemoglobin electrophoresis or HPLC, which picks up the abnormal hemoglobin and it will identify whether you are a carrier. And then you can investigate your partner so you know whether both the parents, the proposed parents, are carriers or not. That is the first and foremost important thing, that identify whether you're a thalassemia trait or not. And it's not a social stigma, it is prevalent, it's quite high prevalent in India. 3 to 5% of Indians are carriers. In fact, in certain ethnic communities like the Gujaratis, the Sindhis, Kachis, Punjabis, Bhanushalis, the Lohanas, the Neo Buddhists, this incidence of the thalassemia trait may be as high as 15%. So it's not a social stigma. You must identify yourself to be a trait. In fact, there should be an awareness right from the school children to the college students that they must get tested, identify whether they are traits or carriers. And this is important in planning a pregnancy because there is something called as pre-implantation genetic diagnosis. So you can diagnose a thalassemia major before the child is born, so you can abort or prevent such a case to happen. So this is one of the most important prongs of prevention. One is awareness. Second is to identify whether you're a carrier and your spouse is a carrier or not. And then pre-implantation genetic diagnosis, which will prevent the child to be born with thalassemia major, which is a disease.
So if the spouse or the partner is not a trait, is not doesn't have the thalassemia trait, then does that mean that there is no risk, or is it that both the parents must?
No, so both the parents must have the trait. So if the partner does not carry a trait, then there is no further need of testing, just to identify whether the child is a carrier or not. But that disease, that individual is not having a disease and he will remain asymptomatic. So if your partner is not a trait, it's unlikely that you will have a child who will be born with thalassemia major.
And when you say that when you talk about thalassemia major or the so what are the different types of thalassemia? We've heard about alpha, beta, and then there is the classifications under beta. So how do you really what do these terms mean?
Yes, exactly. So based on where the defect lies in your hemoglobin, as I told you, that defect is a genetic defect. It is conferred in the genes and it is in the hemoglobin protein. So depending upon which chain is affected, We have something like alpha thalassemia, and similarly, we have beta thalassemia. These are just names based on which chain of the hemoglobin molecule is affected. Both of them are autosomal recessive inherited. That means both your parents have to be carriers for the baby to be born with thalassemia major. And there is another classification based on the severity of the thalassemia. So there's something like thalassemia minor. That is again a trait or a carrier state. It is not a disease. Then there is thalassemia intermedia and thalassemia major. This is basically differentiated on the severity. So a thalassemia major requires lifelong regular blood transfusions to survive, whereas a thalassemia intermedia may require intermittent blood transfusions, does not require so many transfusions as a thal major. So this is just based on the severity of the disease.
Right. So what are the main signs and symptoms of thalassemia in its most severe form and in its minor form?
Okay. So like I said again, thalassemia minor is a carrier. It is asymptomatic. The low hemoglobin on the CBC does not mean anything. These individuals do not need prolonged iron supplementation. And the extreme end is a thalassemia major, which is a full-blown disease. Usually the babies will manifest between the first 1 or 2 years of age with signs of anemia. Why? Because there is decreased red blood cell survival. So they'll come with poor growth, poor appetite, and they will need regular blood transfusions in order to survive. Then as they grow on, because of iron chelation, that is due to the over exposure of blood transfusions, they have excessive iron overload in their body. So they start showing signs of iron overload. So again, that is poor growth, delayed puberty, short stature. They may have defect in the bones. So they may have fractured, propensity to fracture their bones, osteoporosis. They have many endocrinal problems like hypothyroidism, delayed growth and delayed puberty, etc. Also, severe iron overload can affect the heart and the liver, which can cause a shortened lifespan.
So we already spoke a bit about how it is diagnosed in the carrier. So in a thalassemia, if there is a suspicion that the person has thalassemia major or minor, what are the investigations that are then done?
Yes, so it's similar to that in a carrier. We do a complete blood count. We will see a low hemoglobin with low red blood cell indices. We see a peripheral smear, which is a typical for any hemolytic anemia. And of course, the HPLC or the hemoglobin electrophoresis, which will show us the abnormal hemoglobin variant or a high amount of HbF. And lastly, we also now have DNA tests so that we can pick up the exact mutation or the mutations which are known in beta thalassemia major.
Right. So now, could you tell us about the treatment part of thalassemia? I mean, we did talk about the blood transfusions. So what are the different modalities of treatment available?
So as soon as you're diagnosed with thalassemia major, it will be when you're 1 or 2 years old and you will be in a state of severe pallor. So the child will start requiring blood transfusion, and they will require regular, safe blood transfusions at regular intervals, 3 to 4 weekly, and this is a lifelong process. After the first 15 to 20 blood transfusions, we have to start them on oral iron chelators or maybe IV, depending on how severe the form is of iron overload. And these drugs go hand in hand with your regular blood transfusions because they prevent the complications of iron overload. They also need to be supplemented with folate and calcium supplements, which will help their musculoskeletal development. So this is just to, this is required, the bare minimum treatment, which is required for a thalassemic, because he will not be able to survive without regular blood transfusions. But if you're asking for a cure, yes, the only curative treatment for thalassemia major today is a hematopoietic stem cell transplantation or a bone marrow transplantation, which is done preferably with an HLA matched brother or a sister, sibling of a thal major.
So could you tell us a little more about the BMT, like, how is it exactly done?
So, bone marrow transplant is nothing but replacing your diseased bone marrow cells that is not forming the normal hemoglobin by normal stem cells. They have to be matched for the success rate to be good, or the outcome for a benign disorder like thalassemia to be as high as 80 to 90%. It is preferred to have an HLA matched stem cells, which is obtained from the brother or the sister of the index patient. And these stem cells are obtained either from the bone marrow or the peripheral blood, which is primed with GCSF. The patient's bone marrow is initially ablated with chemotherapy, so it's a long, lengthy process, and then you replace it with the normal stem cells, which is nothing but like an infusion of a blood transfusion. But the post BMT care is very crucial. It takes almost 6 months to 1 year. The child needs regular follow up. But once the transplant is successful, and in most of the centers, a matched sibling transplant, when it is done at a right time, the outcome is as high as 80 to 90%. That means that child will be cured of thalassemia major and will not require lifelong blood transfusions. So the only cure available today is a bone marrow transplant. It has to be done in a center which is practicing thalassemic transplants. Also, it has to be a matched sibling transplant. And the cost of the transplant in today's day is anywhere between 10 to 15 lakhs, depending center to center.
And the success rate, as you said, is over 80 to 90% if it is properly matched and done at the right centers.
Yes, absolutely.
Also, one has heard about cord blood transplants or something like that. I mean, what is that? I mean, is that the same as marrow transplant?
Yes, so basically a stem cell transplant or a bone marrow transplant is the same procedure. Just the name is different, like cord blood transplant, because the source of the stem cells are the cord blood. That is from a newborn baby. It is kept and stored if the patient has a sibling. Similarly, a bone marrow transplant, the source of the stem cells is the bone marrow. But now, with the advent of peripheral blood stem cell transplant, that means the stem cells are procured just from the peripheral blood after priming the sibling with GCSF. The incidence of cord blood transplants has gone down. It's not really practiced. Peripheral blood stem cell transplants or a bone marrow transplant is preferred in case of a thalassemia major. In most of the centers, I don't see anyone practicing cord blood transplants.
And you were saying about the timeliness of the procedure. So what is the right time then to do the procedure?
So ideally, the time should be before 8 years of age, so that the child does not have any major complications of severe iron overload. There should be no hepatomegaly, no liver fibrosis, because that is because of excessive transfusions that causes deposition of iron on the liver. These will increase the complications when the child undergoes the transplant and hampers with a good outcome. So ideally, before the age of 8 years and a matched sibling, these two things are critical for the successful outcome with the bone marrow transplant.
Right. So if there is a child, I mean, before the transplant and living with these multiple blood transfusions, are there any lifestyle? I mean, I know that the child will be having a very difficult time, will be struggling with all these transfusions, but how easy is it for them to, have a fairly normal childhood, as in go to school, and will they be able to play sport, or will it all be too difficult for them to cope?
So if a child is given a regular transfusion with every 3 to 4 weekly and maintained on a tight iron chelation, so that means they don't let the ferritin go too high, and is on well supplemented with his folvite and his calcium supplements, goes for an annual or a biannual checkup with a multidisciplinary team or in a comprehensive thalassemic center where you have not only the nutrition support, but the pediatric hematologist, also the pediatric endocrinologist, cardiologist, who will monitor the child at each and every step for any complications and then manage the complications. These children, up to the first or 2 decades of life, have a fairly good quality of life. Important thing is they have to be regularly transfused. So you cannot delay your transfusions. Your pre-transfusion levels have to be anywhere between 9.5 to 10. And this is not your post-transfusion, but your pre-transfusion hemoglobin levels. You have to be taking your oral iron chelators very regularly. There should be a constant supply. And if these two are kept well, of course, you need to have a good, healthy lifestyle. You need to incorporate healthy diet, exercise regularly. This is a must for all children for a normal musculoskeletal development. Fairly, with this tight schedule and a good multidisciplinary care, the quality of life is definitely improving as we see 2 decades earlier.
Absolutely. Also, people wonder, like, if supposing there is a person with a thalassemia trait and the partner too has a trait. So what are the options that they have for having babies?
So, of course, like I explained you, not
Yeah.
every pregnancy with both the traits is going to end with a thalassemia major. So, with every pregnancy, you only have a 25% chance, if both the parents are traits, that the child will be a thalassemia major. And this can be picked up by pre-implantation genetic diagnosis. You can diagnose, if you know the mutation, you can pick it up at 11 weeks of pregnancy. So you do not need at the early stages of embryonal development. So we can terminate the pregnancy. So, and there are 50% chances that the babies will be carriers. So that is just a thalassemia trait, which is absolutely okay. They have a normal life, they do not have disease. And there is 25% chance that the child can be absolutely normal even without a trait. So each pregnancy confers only 25% chance that the baby can be a thal major, and this can be easily prevented when you know that both the partners are traits. So there is no contraindication to marry or to plan a family when both the partners are traits.
So I think the key is to be aware that you are having the trait. Yes.
Absolutely.
And what about people with thalassemia major? What about their chances of having a child, getting married? Is that a possibility?
So, in today's scenario, compared to 2 decades back, it's not a bleak chance. It's definitely because of the improvement in chelation and regular transfusions and management of all the complications, it is possible. It also, of course, depends whether the partner has a trait, partner is normal, then it is not a dismal chance. There is nothing that they cannot conceive. And of course, they always have a chance of adopting. So it's not that they cannot lead a normal life, cannot get married. Thalassemia majors even have underwent successful pregnancies. There have been so many case reports. So there's nothing to be disheartened. With the good regular transfusions and chelation therapy and a proper adequate lifestyle, it is possible.
Is there anything else that you wish to add, Doctor, to the
I think it's just as we are meeting up on the Thalassemia International Day, this is an ideal platform to create awareness about thalassemia major and even about thalassemia minor. It is not a stigma, so parents should not hide if they know that their child is a minor. In fact, you should go out and encourage and test for a thalassemia trait, because awareness and prevention are the only two prongs which will prevent or reduce the global burden or the economic burden which thalassemia major has. And it is not disheartening. There is a cure. If you have a sibling, bone marrow transplant has got a good successful outcome in the right centers, almost up to 80 to 90%. So there is a cure even for with adequate timing and a match sibling. These two are the prerequisites. So that's the only thing. The message should be aware of thalassemia, what is a thalassemia minor, and also an appeal for everyone to go out and give blood. So blood donation, which is one of the very important prongs which these children need lifelong. So without the blood donors, we will not have the supply of safe blood. So it's an appeal to everyone hearing this that please go out for a blood donation. Thank you.
Thank you so much, Doctor. So I hope, viewers, that you had an illuminating discussion about thalassemia. The International Thalassemia Day is devoted to raising awareness amongst the general public, decision makers, governments about thalassemia, promoting and strengthening the lifelong struggle that patients have, highlighting the new treatment options, motivating them, and as doctors said, giving them hope that it is not all dismal and bleak, and there are many new ways of treating it, and also remembering all the people who have had thalassemia in the past and who are probably not with us anymore. And for them and for everybody else, we renew our promise to keep fighting until the final cure for thalassemia for everybody is found. So let's be aware, let's share information, spread awareness within our society, within our community, so that people are aware of thalassemia. And as doctors said, raise awareness on the need for blood donations as well, and help in keeping the safe supply of blood flowing for these children who will need that lifelong support. So if you have any more queries, you know that we're always available on all different digital channels, social media channels, as well as in all our hospitals across the country to assist you at any time. So take care and see you soon. Thank you. Namaste.